Is the back, and today it is going to be discussed is anterior petrosectomy. So we have very experienced speakers, three speakers. Dr. Arun Srivastava from the ACPGI Lucknow, and he'll be talking on the anatomical aspect of anterior petrosectomy. And then another speaker, very experienced, Professor Ashis Suri from the All India Institute of Medical Sciences, Delhi, and he'll be discussing about the extra-dural anterior petrosectomy. And we have Professor Sunil Gupta from the PGI Chandigarh, professor and head of Department of Neurosurgery, and he'll be talking on the tailored anterior petrosectomy for the intra-dural approach for the anterior petrosectomy. And to discuss at length, we have very senior neurosurgeons of our country, past president of Skullbase Surgery Society of India, Professor B.K. Misra and Professor Suresh Nair. They are my teachers too. We have learned so many things from them. And to start, I will just show a few slides about this region. What are the lesions which appear in this location? So these are the surgical lesions which usually occur in the petroclival area. Most common is the petroclival meningioma. There are chordomas in this location and schwannomas, epidermoid, and there are some other lesions. Whether you can see my slides? No.
Yeah, it's visible.
Visible?
Yeah.
We can see, sir. We can see.
But this slide's not moving.
Sir, you can put into slideshow, sir.
So the difficulties in this location is because these lesions are very deeply located and there is a complex neurovascular anatomy. There is a severe brain stem compression because of these lesions and very important neurovascular structures. And you have to, because the lesions are very deeply located, so a lot of brain retraction comes. So these are the difficulties to access these lesions. As far as approaches are concerned, there are a lot of approaches which you can access.
Slides are not moving, sir.
Lateral approaches, frontotemporal, lateral suboccipital, posterior petrosal approaches, extended middle fossa approach, which is commonly known by Kawase's approach or lateral extreme lateral transcondylar approach. So today we are going to discuss this extended middle fossa approach, or also known as the Kawase's approach, or Dowling-Kawase rhomboid or anterior petrosectomy, to access these lesions. And I request Dr. Narasinga Rao to introduce the first speaker, Dr. Arun Srivastava, for his talk.
Yeah, thank you. Thank you very much, sir. Just want to share his small CV slide. Are you able to see his slide? The slide?
Yeah.
Yeah. Dr. Arun is now presently the faculty in SGPGL Lucknow. He's a well-known good friend of mine, as well as he is well-known among a younger generation of neurosurgeons. He did his MBBS from Bellary, moved to Allahabad for doing MS, and then finally ended up quite north place, now All India Institute of Medical Sciences, Delhi. He finished his MCH. He did his fellowship, one from Japan and another is from Arkansas, USA, where he was trained by none other than Ali Crest, who is the brand name for the transcavernous surgeries. He has to his account some more than 200 publications. His areas of interest are mainly the skull base and vascular. And I know that he's a good singer, but today morning I asked for a CV slide of him where he shared that he is the chairman of SGPGA cricket team also. So he is multifaceted. He's a good singer. I always enjoyed in conferences and meetings his melodious voice. And all stage is yours, Arun, about the anatomy. So he will be speaking on the anatomy of anterior petrous apex. Thank you.
So, a very good evening to all, and thank you, boss, for at least 2 decades. First time someone called me young and young neurosurgeon, and I'm so very happy with this comment. I think my slides are visible.
Yeah.
Yes.
Right. So, a very good evening to all, and thank you, Skullbase Surgery Society of India, for giving me this opportunity. And I'm going to share the applied neuroanatomy in relation to the anterior transpetrosal approach. The petrous bone is a very important, interesting, and I will use a word mysterious part of temporal bone. And we know the temporal bone has 5 parts: squamosal part, mestoid part, tympanic part, stolite part, and the medially projecting bone known as petrous bone. And this bone, as Kachhara sir rightly said, it's in the center of skull base. And this encloses vestibule, semicircular canal, facial canal, carotid canal, and cochlea. So I'll tell you why I have used the word mysterious. Because most of my target audience, I believe, are young faculty, residents who want to travel in this area. And what happens once they don't know the nuances related to this very area? They land up with morbidity, difficulty, bleeding, and other issues. And then what happens? They start blaming the beautiful microneurosurgical approach as well as endoscopic approach. And we take a very simple route of subjecting our patient for easier thing like gamma knife, other stereotactic radiosurgery, maybe biopsy, and incomplete job. So what this phenomenon known as in Oxford Dictionary as a complexity trap, and my young colleagues are gradually getting trapped in this complexity trap. So, sir has rightly shown the pathologies. You know, even I would like to attract all my young faculty with the pathologies which can be cured with this anterior petrosectomy approach are well addressed in terms of good outcome. So, as Sir said, the literature divides the pathology in and around petrous apex as an intra-dural pathologies, extra-dural pathologies, and one more subset. And I think Dr. Narasimha and other skull-based people are going to love that very subset. What I understood over the year is extra-dural intracavernous. So, Sir's rightly shown that petrous meningiomas, and this is a case of we thought maybe we are dealing with fifth nocenoma, but turn out as a fungal mass. So very well addressed through this approach. Multi-compartmental epidermoid, mainly into the prepontine, ambient, and supracellular systems. And this is a very interesting case of a 12-year-old child turned out as a clear cell meningioma. And the tentorial incisural meningioma. So these are the very curable, except for the fungal mass, curable lesion present in this area. I think I'm audible.
Yeah.
Yeah.
Very much.
So,
Very much.
so the second means one very big subset of fifth nocenoma, whether it's a pure middle cranial fossa, fifth nocenoma, posterior fossa, dumbling, they can be addressed because these lesions they does the auto Kawase removal. I mean, this bony removal. They themselves erode the bone and helps in completing the Kawase quadrilateral removal. So these are all curable disease, can be very well cured with anterior petrosectomy if we learn the anatomical perspective as well as surgical nuances. So my great two teachers, Professor Dr. Suri as well as Dr. Gupta, are going to tell you the surgical nuances. So I'll be trying to cover all the possible surgical anatomical perspective, anatomical things which will simplify your understanding and then further surgical approach towards this area. So as I said, one is intra-dural pathology, second is the extra-dural pathology. And cholesterol granuloma, cholesteatoma, these kind of collection present there can be simply addressed with endoscopic route, that is medial transsphenoidal route, and that you can very well drain into the nasal cavity, and sometime you can put some small drainage system for that, and that is all you have done, you have cured the patient. The third subset, what I was talking about, is a very interesting subset. See, we have talked about many approaches, but after visiting Arkansas, and I understand some anterior petrous pathologies, they actually grows inside the cavernous sinus, and then you don't require Kawase approach for anterior petrosectomy. You can do the complete job through transcavernous approach, and I'll show you with one interesting video. So these pathology, I used to call it as a extra-dural intracavernous. They are usually petrous chondrosarcoma and sometimes clival chondrosarcoma, clival chordoma, sorry. So now coming to the anatomy. This bone of interest is sandwiched between the greater wing of sphenoid and occipital bone, mainly the clival part. This bone is having three margin: superior margin, anterior margin facing toward the middle cranial fossa, and the posterior margin facing towards the posterior cranial fossa. Then because of this, it has three surfaces: anterior surface toward the middle cranial fossa. Most of the time we are interested in this anterior and posterior surface, right? And then a apex and the base. And near the base, it is actually harboring those important structure, as I mentioned: vestibule, semicircular canal, facial canal, carotid canal, and cochlea. So these are the important structure. If we understand, we will not be damaging and we will be doing the complete job. So superior margin actually has a sulcus for superior petrosal sinus, and here the inferior margin has a furrow, a groove for inferior petrosal sinus. So little bit about the cavernous sinus. See, this is the photograph taken from Rotten. You see the cavernous sinus, the posterior part is very bulky in human beings, and that is known as basal sinus. And that drains to the transverse sigmoid junction through the superior petrosal sinus and jugular bulb through the inferior petrosal sinus. So now these two important venous sinuses are coming in our way when we are performing anterior petrosectomy. So now, just summarizing here: three margin, three surface, one apex, one base, and base, near the base, it is harboring important structure related to your seventh and eighth cranium. Now the approaches. The literature says, I mean, this is a review article by K.V.L et al., that there are anterior approaches. I'm just going through this, but not be discussing in detail that medial transsphenoidal approach with lateralization of internal carotid artery, transpterygoid infrapetrous approach, and translateral approaches. Sometimes they can do transmaxillary anterior petrosectomy with this endoscopic approaches. And there are lateral approaches as a part of complete petrosectomy. There you can remove the anterior petrous as well, which are translabyrinth, transcochlear kind of approaches. That too is not my today's point of interest to discuss this very approach. I'll be discussing mainly the anterolateral approach, that is open anterior petrosectomy. Okay, so I am going to talk about the anterior petrosal approach. So anterior petrosal part, yeah, anterior petrous is also known as petrous apex. And this is the bony part of the petrous medial to the medial border of the internal acoustic meatus. I'll show you with further other slides. And I said this is sandwiched between two very important bone, the greater wing of sphenoid and the occipital bone, mainly the clivus part. How you will see that fifth nerve with all three division, middle meningeal artery through the foramen spinosum, and then this part arcuate eminence, and then part lateral to the internal acoustic meatus, and then actually this blue is our a bone of interest, which I'll be trying to tell you all the possible nuances related to the anterior petrosectomy. So this is a just rotated image. As I said, this is the internal acoustic meatus. Now this is the surgical image. What we get when we take a patient of right-sided, malar up, rotated maybe 45-degree to the opposite side, and we have performed a right frontotemporal craniotomy. We have retracted the temporal dura for complete drilling. You will see this is our bone of interest. So the medial border of the internal acoustic meatus is the posterior limit of our anterior petrosectomy. The GSPN covering going over the petrosal part of the ICA is the superior limit. Medially, actually, there is a part of the bone which is known as trigeminal impression. That is actually a concave kind of part of the petrous bone where this fifth nerve ganglion is resting, is known as petrous impression, is the medial most part. So Professor Suri in 2005 used to tell me that Arun, actually it is not a Kawase triangle, it's a quadrilateral. And with blessing of teacher like Dr. Suri and Dr. Suresh Nair and my other great teacher, I understood it is not only quadrilateral, it's actually a pentagon. It's actually a structure which you can expose like this to have a very nice exposure of the posterior fossa compartment structures. So I'll take you through the cadaveric stepwise dissection to understand how to perform a safe anterior petrosectomy. Now here in this cadaver dissection, the craniotomy is not what I was talking about. After learning from the Japan, I used to turn this skin incision right up to the highest point of the pinna, and that with practice you will understand why I am doing this. I cannot cover that very part, but because you want to sit on the base of the root of the zygoma, and that is why you require this incision slightly to be modified. Then after that, simple steps, whatever your center follows for the muscles, like we follow a cover technique, we try to do the zygoma only small, drilling, and that is known as zygoma lowering technique. We have already published it. And then craniotomy based on the root of the zygoma. Actually, the point of interest is root of zygoma. And after craniotomy, you are going to have some measure to make the brain lax. And my senior teacher will tell you the tricks of making the brain lax. And after that, once you will retract the dura, the first structure you are going to encounter is the middle meningeal artery inside the foramen of spinosum. So you have to coagulate and cut this middle meningeal artery close to the foramen. And once you have cut this middle meningeal artery, you will get the second structure is foramen ovale harboring the third division of the fifth nerve. And here, what most of the skull-base surgeons prefer in moderate to large size tumor to open or dilate this dilatation of this foramen of ovale for mobilization of this mandibular division of the fifth nerve. That will help, and that will be discussed by Dr. Suri and Gupta sir. And then after this, what you see? You see after the reflection of dura, lateral to medial structure. I'll take you through this image, lateral to medial structure. The first structure you will get a very thin papery bone known as tegmen tympani. And you should be very careful. This is papery thin. If you rupture through this, that can lead to the leak towards the external acoustic meatus. And then there is elevation. This elevation is known as arcuate eminence. And this elevation is because of the superior semicircular canal. So you try to understand why these structure are having specific pattern, because some important structure is lying beneath it. And then there is a depression. This depression is of internal acoustic meatus. Then again there is an elevation. And this elevation is known as trigeminal elevation because it's just lateral to the trigeminal nerve. And beneath this fifth nerve ganglion, you will get a depression known as trigeminal impression in the anterior most part of the petrous bone. And if you really want to do complete job, you have to drill that part as well. So this is the superior margin, but in your surgical exposure has come on the inferior part is superior petrosal sinus. And somewhere here, you will get the inferior petrosal sinus. So this is the bone over the internal acoustic meatus has been removed. You can see the GSPN. You can see the petrous ICA. In 15 to 20% of cases, in the medial part of this petrous ICA, the bone is dehiscent. And in my experience, in 15 to 20%, the bone are dehiscent. And in another 15 to 20%, if the bone is there, it's very, very thin, papery thin. So be very careful when you are manipulating with your dissector somewhere here, or never use monopolar, and be very careful with dissection here in this area. So this is the medial border of the internal acoustic meatus. The bone medial and anterior to this is petrous apex. That's what we are going to drill in the anterior petrosectomy. Now, going through another cadaveric photographs. So you are coming from lateral to medial, posterior to anterior. So this elevation is arcuate eminence. This groove is of internal acoustic meatus. This is the bone from medial to this, all is actually the anterior petrous bone. Now, few things I would like to mention here. The greater superficial petrosal nerve becomes a very important landmark. So when you are coming from lateral to medial, that is known as retrograde peeling. So if you are peeling the dura, please remember this greater superficial petrosal nerve lies beneath the periosteum. So if you are, dissecting the periosteum off from the bone, you will injure the greater superficial petrosal nerve. Rather, you will be doing a lot of traction over the geniculate ganglion, and that will in terms lead to the seventh nerve paresis or palsy. So be very careful. And in some situation, the greater superficial petrosal nerve due to some reason has gone. You don't have that landmark in your view. What to do then? Then this arcuate eminence, the, 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 the inferior part of this arcuate eminence serve as a an angle to be made from this arcuate eminence, this line, a 60-degree angle, to understand where is the internal acoustic meatus. Second thing is GSPN, you want to save petrosal part of the ICA. So you do one thing, mobilize this mandibular division of the fifth nerve, slightly elevate it off the bone. You will see the part of this ICA here. So you should be very careful. You will see the ICA and you will understand what is the course of petrosal ICA in your area of interest. So that is how you should be negotiating with something which goes wrong, because we understand greater superpetrosal nerve is a kind of thing, structure which guides everything. No, it's not like that. You can take help of other anatomical landmark in the vicinity of your surgical field. So here the petrosectomy has been performed, right? You can see the superior petrosal sinus. Even the bone over the internal acoustic meatus has been removed. The bone of trigeminal impression has been removed, and this much wide posterior fossa dura you can see. Superior, this you can see inferiorly the inferior petrosal sinus. Superiorly, you can see the superior petrosal sinus. Now, please understand this anatomy. The fifth nerve is coming like this through a dural kind of ring to the from the posterior fossa to the middle fossa. So while cutting this dura, sometime if you are not aware of this fact, you will be cutting through the fifth nerve and then you will be going to the posterior fossa dura. So the trick is try to cut lateral to this fifth nerve and then give a T-shaped incision. Otherwise, try to understand you can get a fifth nerve bang on your cutting dura. So be very careful. Cut it in the with a small millimeters of incision. So these few important tricks to be remembered when you are doing the anterior petrosectomy. Now, why I said you should be knowing what are the structure are situated beneath or inside the petrous. That will give you insight why I am not drilling, why I should not be drilling, why people take a precaution while drilling this anterior petrous on this side and that side. Why? Because you see this arcuate eminence is actually because of the superior superior semicircular canal, and then here is the geniculate ganglion. So just the most inferior part of the arcuate eminence, somewhere here is the geniculate ganglion. And then you see the cochlea. Cochlea is actually situated here between the angle formed by the greater superficial petrosal nerve and arcuate eminence. So there is an angle formed, and that angle is known as cochlear angle. And actually, cochlea is situated here. If you will drill through, you will be injuring the cochlea in this area. So that is why when we mark this, petrous apex, we leave a small amount of bone, 2 to 3 millimeter bone here to avoid cochlea, and that to our angle trajectory of drilling is not towards this. The angle of and trajectory is like this: lateral to medial, lateral to medial, lateral to medial. So see, this is the meatal segment harboring the seventh and eighth nerve complex. This is the fundus of this seventh eighth nerve, where the nerves are in very close relation. If any thermal injury due to the drilling, any direct drilling of this area, you will be producing cross defect as far as seventh eighth nerve complex is concerned. And here actually they are means slight away from each other. So here you can do the drilling, bony drilling, and if required, then only the dura is divided. Otherwise, only bone is removed in large petroclival or trypanosoma cases. So these are the underlying structure in relation to your anterior petrous. So again, continuing with the surgical steps. So you'll go and you will get the first structure, that is middle meningeal artery near the foramen of spinosum, coagulate and sharply cut it. After cutting it, you have two options: either come from here lateral to medial. What I prefer, I go to the foramen ovale. I widen the foramen ovale to mobilize the mandibular division of the fifth nerve. But after this, I used to come from lateral to medial. I used to see the tegmen tympani. I used to see the arcuate eminence. And here I used to do the sharp dissection, understanding somewhere.
Dr.
near.
Arun, Dr.
Yes.
Arun, just a moment. Can you wind up, because Gupta sir is also getting late.
Okay, okay. Well, I mean, sir, it is very relevant. If you can allow me
Yeah,
after some time. I mean,
yeah, but
have it taken the sufficient time?
yeah, I think so, because
So you give
18
me
minutes is the time which is
you give me
given.
2 minutes.
Yeah.
I'll bind it.
Yeah. Thank you.
So right.
That would be great.
Hello.
That would be great.
Hello,
Hello.
Arun. Arun, you can continue for some time. No, I
Ah.
think it's very important which is going on.
Okay, sir. Okay, sir. Right. Thank you, sir. So, one thing I would like to address is the landmark for the internal acoustic meatus. So, with arcuate eminence and geniculate ganglion is preserved, this makes a 120-degree angle. You bifurcate it. This is the line for internal acoustic meatus. Another way is it is in the continuation of external acoustic meatus. Another thing is you can make a 60-degree line with arcuate eminence. So this is okay, done. So that is how you will get the exposure and the drilling, right? So I'll take you through one of my cadaveric dissection. So right-sided approach, you see actually the middle fossa dura has been opened, but please understand this is GSPN. This is the cochlear angle. This is the cochlear angle. So see here we are not drilling, right? And then we are drilling perpendicular to the area where we are suspecting or predicting our petrous ICA. And then you see we are going very medial below the mandibular division of the fifth nerve. And this is possible only after the widening the foramen above. And this is will be shown by the various means our senior surgeon. So this is one operative video I'll skip because it will be shown. But only thing I want to show here for 1 minute is the one very interesting angle of addressing anterior petrous through transcavernous approach. Transcavernous approach. How it is possible? It's very simple. I will take this example of giant petrous chondrosarcoma filling the cavernous sinus, and you will see you can address this petrous area with transcavernous approach. So we have done the right frontotemporal craniotomy with zygoma lowering, followed by posterior orbitotomy. This is the standard approach. Steps, orbitomeningeal artery, posterior orbitotomy completed. This is buckled up orbitomeningeal band. So we are cutting the orbitomeningeal band. And then the dural duplication is already dissected. So very easy. Now you see, I am going through the Moulin's triangle between the V1 and V2 division, already separated. And then you will see the beautiful petrous area anatomy through the transcavernous approach. And it is possible. We have done many cases through this approach. So this is the mandibular. We are medial to the fifth nerve complex. I see this is the petrous ICA. You can see the petrous ICA. You can see the GSPN through the transcavernous corridor. See, this is the GSPN. This is the sixth nerve draping over the petrous, ICA in the cavernous sinus, medial to the petrolingual ligament. Now you see the Gasserian ganglion. And now you see the beautiful complete petrous harboring the tumor, just like this rodent's anatomy. You can compare these structure with your surgical anatomy. So this is possible through the transpetrous approach as well. So I'll, due to the paucity of time, I leave other component, mainly some endoscopic approaches for petrous apex. You can, for cholesterol granuloma, you can take medial transsphenoidal approach. For some cases, you can do medial plus IC lateralization. You can go for the transpterygoid infrapetrous approach, right? Like we have done in this case of skull-base osteomyelitis and contralateral transmedullary approach. So I would like to acknowledge support from my team and Dr. Ravi Shankar and Dr. Amit Kesri from neurotology, and definitely my anesthetist and my IONM team. Thank you so much for patient listening. Thank you.
Thank you, Arun. That was a wonderful talk. Crystal clear presentation as usual. I'm really sorry because the
No
time
problem.
constraints are there.
In
Sorry to interrupt.
In excitement, I really didn't notice that, it's like a
No, that's fine. That's fine. Perfectly fine.
morning class.
Yeah. Is the presentation of Dr. Gupta sir is ready? Is the, from the
Yeah,
sir?
So I will share my slides.
Sir, you can share your slides. Dr. S.K. Gupta is well-known neurosurgeon, skull-base area with the area of skull-base interest. He is the professor and head of the department of PGI Chandigarh, and he's been the secretary. He's been the president of Skull-Base Surgery Society and various other societies of national and international reputation. Sir, you can go ahead, sir.
So are my slides visible?
Yes, sir. Yes, sir. Very much.
So good evening everyone. I'll be talking about intra-dural petrosectomy. At the outset, I would like to make it clear that this is not choosing between extra-dural and intra-dural. The choice of doing an extra-dural approach or intra-dural approach is determined by the tumor, not by any particular preference, but for example, for trigeminal schwannomas, most often I will always use a extra-dural or intra-dural approach. For meningiomas in this region, I prefer an intra-dural petrosectomy. So classically, for lesions in the zone 1, we do anterior petrosectomy. For zone 2 lesions or tumors, we do a posterior or combined petrosectomy, which I have almost stopped doing now for posterior combined petrosectomy. And classically, for tumors in the zone 3, we prefer a transcondylar approach. So to approach the petrous bone here, there are 3 routes. One is the subtemporal route as described by Kawase extradurally. Second is a retrosigmoid route where you can drill the suprameatal segment here and this bone can be drilled. The third one which I will be talking about is along the sphenoid ridge. So this approach has been described by authors previously also. There is an article describing limited intradural anterior petrosectomy for upper basilar aneurysms. However, this was a subtemporal approach. I do not like a subtemporal intradural approach for a petrosectomy because there is a lot of temporal lobe retraction which can sometimes cause problem. So another author also described an interdural anterior petrosectomy. Again, this was a subtemporal approach. Intradural subtemporal approach. So my technique, which I described more than a decade ago, is an anterior intradural petrosectomy, specifically for petroclavial meningiomas. So the standard craniotomy which can be done for this is a frontotemporal-orbitozygomatic craniotomy, or sometimes a terional craniotomy with or without anterior craniodectomy. And I do a trans-Sylvian trans-tentorial approach. The tentorial incision is used to approach the lesions which are in the upper petroclavian region straddling the middle fossa and the posterior fossa. And this is suitable for lesions which are anterior and superior to the internal auditory meters. Lesions which extend below it or posterior it are not suitable for this approach. So once you have done an FTOZ, this is the bone which can be removed. Then you follow the tentorium in the long axis of the tentorium and long axis of the tumor, and you reach this bone here, the anterior petrous bone. The relevant anatomy is shown here. This is a cadaveric anatomy. These are the optic nerve, the carotid artery which has been cut. This is the tentorium, the third nerve entering the roof of the cavernous sinus here. And this is the fourth nerve coming from the behind the brainstem and entering the free edge of the tentorium. Sometimes the tentorium has to be lifted to see this nerve. And you see here, this is the posterior clinoid process and the dorsum celli. And this is the petrous bone. If you cut the tentorium here, you're right onto the petrous bone, and this depression here is the Meckel's cave, which houses the gastric ganglia. So further, same dissection, the tentorial edge, the optic nerve, the carotid artery. This is the third nerve seen here. The fourth nerve is not seen, probably because it has been cut. And once you cut the tentorium here, you are on the gastric ganglion. And you retract the gastric ganglion medially. This is the petrous bone which has to be drilled. The landmarks for the drilling for intradural petrosectomy remain the same as in extradural petrosectomy. Only we are doing from the intradural approach. This is the brainstem here. And once you drill the petrous bone here, you have access to the posterior fossa here, lateral to the gastric ganglia, which can be retracted for the tumor removal. And you should not go beyond the 7th-8th complex because this causes injury to the 7th-8th complex as well as the ICA and its branches. So this is the limit of petrous bone drilling. Just showing the relevant anatomy in a diagrammatic manner, the optic nerve, the third nerve, the tentorial edge, the fourth nerve coming here. And once you cut the tentorium, you see the fibers of the gastric ganglion. You see this for the third nerve, fourth nerve, and fifth nerve. They're all in the same line in your line of vision when you're operating. And this is the petrous bone which has to be drilled. So why I say tailored anterior petrosectomy is you are initially doing a tumoral decompression. And sometimes the tumor itself has done a petrosectomy for you. So you remove only that much of bone as is required. This job may have already been done by the tumor itself. So this is a tailored petrosectomy depending on the need. Sometimes the tumor is soft, you need not do a very extensive petrosectomy. If tumor is firm and fibrous, you have to do a more petrosectomy. So you determine the amount of bone you have to remove depending on the consistency, and the nature of the tumor. This is a standard FQZ which can be done. And after do you FQZ, you have the orbit, the frontal lobe, the temporal lobe, the sylvian fissure here. Once you open the tentorium, do a transsylvian dissection, the temporal lobe falls away. The optic nerve, carotid artery, tentorial edge, third nerve, brainstem, then tentorium as we cut here. So the transsylvian intra-dural anterior petrosectomy is particularly useful for petroclival meningiomas because they are usually firm, fibrous and vascular, and sometimes they encase the neurovascular structures, which may be hidden behind if you come from the outside. And the perforators can easily be damaged if they are not in your view. So the craniotomy, as I said, can be FTOZ or a craniotomy. The sylvian fissure is widely opened because this allows the temporal lobe to be fall away, and it can be detected posteriorly and laterally. Tumor is identified and is in relation to the optic nerve, third nerve, and eye is identified. So the tentorium is incised posterior to the entry of the fourth nerve. Intertumoral decompression is done first, and after that we decide how much Peters bone has to be drilled. And we are working along the long axis of the tumor, which is the best axis to work upon. The dura incised of the Peters bone elevated, and this Peters drilling is combined with frequent intertumoral decompressions. Just showing you short video of the initial steps of the approach. You do a wide sylvian fissure dissection, preserving all the veins. This is the tentorial edge which is seen here. We are cutting the tentorium, coagulating the tentorium. Although it's a very old video, but you can still see the fourth nerve here. This is the tentorial edge. We're peeling the arachnoid away from the tentorial edge to visualize the edge. Cut the tentorium to have a look at the tumor. And then after cutting the tentorium, you do intratumoral decompression, peeling the arachnoid away from the tumor. This is the brainstem seen here, and this is the thin fourth nerve seen here. So we are doing further intratumoral decompression. At this stage, I have to take a call whether to go ahead with petrosectomy or not. If the tumor is coming by itself and is under vision, I don't do a petrosectomy. But if the tumor is fibrous and not coming in my view, then I do anterior petrosectomy. So this is another short video showing the cutting of the tentorium. You should see I cut the tentorium always from lateral to medial because sometimes the fourth nerve is hidden under the edge of the tentorium, and if you cut from medial to lateral, it can be damaged. So this is the fourth nerve seen here. So cut from lateral to medial. And the next, this is the diagrammatic view of the same approach. The sylvian fissure has been resected, the ICA, the tentorial edge, fourth nerve, tentorial incision given here, decompression, brainstem, fourth nerve. And now again video showing the petrosectomy itself. The tentorial edge is seen here. This is a meningioma which is fibrous and firm. This is a fourth nerve seen here. I will come to this. This is a third nerve which has been severely stretched by the tumor. The tumor is being dissected between the third and the fourth nerve. And this is the Gasserian ganglion seen here. This is a Peters bone lateral to the Gasserian ganglion. The dura is being cut here, and the bone is being drilled lateral to the Gasserian ganglion. Further, after drilling the Peters bone, we get access to the posterior fossa tumor, and this can be removed. So the diagrammatic representation is the same. The third nerve, the tumor, the fifth nerve, fourth nerve, the third, fourth, fifth, all in the same visual axis. Pecom superior cerebral artery, the Peters bone lying lateral to the Gasserian ganglion, which can be retracted, and this bone can be drilled. The amount of drilling can be decided upon the extent of the tumor and the consistency of the tumor. The drilling been done to access the posterior fossa tumor. This is end of the surgery showing a nice tumor bed and total tumor removal. So the advantage of this approach is there is no subtemporal retraction. The temporal lobe falls by itself posteriorly and laterally. We are working along the tentorial edge and long axis of tumor. There is adequate exposure of the middle fossa, and there is a good vascular control of the neurovascular structures also. The exposure is right from the optic nerve to the CP angle. And there's a better access to a vertical supratentorial extension. If the tumor is extending vertically up, you can, if you do extra-durally, you have to do a lot of temporal lobe retraction, which can be avoided by this approach. So this is a tailored need-based petrosectomy with direct access to vessels and nerves, and all perforators can be seen and preserved. Showing some examples of tumors which are being removed by this approach. This is a meningioma. This is a long axis tumor. So the same approach was used and the total excision was done. This is not a meningioma, this is schwannoma, but the vertical extent was quite high. So I did not want to retract the temporal so much. So this was the surgical trajectory and total removal was done of this tumor. Another tumor removed by this approach. Craniopharyngioma extending from middle fossa to posterior fossa. This approach was used. Again, another tumor removed by this approach. Again, working along this long axis, and again, avoid the temptation to have a good post-op CT. It is always better to leave some amount of tumor rather than risk injuring the perforator, especially for large petroclival meningiomas, which I sometimes like to do a planned subtotal resection because the quality of life has to be preserved. So large tumor petroclival meningioma, but a subtotal resection done. This tumor is left behind, and the patient did not receive gamma knife. Almost 10 years of follow-up, there is no problem. The patient has preserved cranial functions also. Other tumor, subtotal removal done, gamma knife given, patient is well preserved, no deficits. Same for another approach. Another patient. So to end, the patients are, why I say planned subtotal for large petroclival meningiomas, because these patients are relatively well preserved perioperatively. Aggressive approaches may increase the risk of morbidity, which can be procedure related, which can be because of perforate injury, neural injury, or vascular injury. So tailored anterior petrosectomy, and one has to have a delicate balance between total excision and preserving good quality of life. Thank you. So
thank you, Dr. Sunil. Very, very nice presentation. Very nice display of cases, and altogether, different approach for the anterior petrosectomy.
if you allow, can you allow me to leave because I have to board now? Sorry, I'm at the airport. So my boarding time is almost 8 o'clock, so I have to go there.
Yeah, you have to go anyway.
I have to go, yeah.
Yeah.
Thank you. Sorry to have missed other presentations, but bye-bye.
Thank you very much.
Have a safe flight.
Bye,
Yeah,
sir.
thank you.
Happy journey.
Bye, bye.
Thank you, sir.
Narasinga Rao, can you introduce Dr. Suri has joined?
Yes, sir. I'm there.
Please, sir.
Dr. Suri is there.
Dr. Suri, I'm not seeing Dr. Suri, sir.
He doesn't require any introduction, sir.
Yeah, obviously he doesn't require. He's the boss of the temporal bone and the skull base. I think he's the past president of Skullbase Surgical Society and professor and head of the department of Unenhanced Medical Science, Delhi. That
Not
should
head,
be,
not head.
sir. Sir,
I'm still
yeah,
the
yeah,
unit
but
head.
going to be the next.
No. I keep myself away from such seats.
Oh, sir, sir, you are not seen. I'm not able to see you in this screen. Just wondering.
Yeah, I'm there.
We
Yeah,
all,
yeah.
Am
Yeah,
I
yeah,
not
that's right.
visible?
sir, you're so, you're
Visible, sir.
signing.
The light may be reflecting on my head. Can I share my screen?
Yes, sir.
Yeah,
Please
go
go
ahead.
ahead, sir.
Just a second. Is it visible?
Yes, sir.
Hi. Yes.
Yeah, very much.
Yeah, this is, thanks to the Skullbase Surgery Society of India, it has and wonderful introduction of the basic seminars and the webinars, thanks to Dr. Bhartiya. I've been assigned, Dr. Roopesh just called me last week, and we speak on anterior transpetuous approach. The anatomy has been covered nicely by Dr. Arun, and Dr. S.K. Gupta has talked about the intra-dural. This is a very topic close to my heart, the central skull base. I always divide the central skull base into the one which is anterior, the one which is posterior, that is microscopic transcranial, and one which is below that is endonasal. So here we'll be talking about the one which is centered around the posterior cavernous sinus and the petrous apex. There's this big spectrum of lesions. When I talk about extra-dural, Why extra-dural approach and extra-dural? Because here you can, it's a spectrum of lesions. If you're only doing intra-dural, then it becomes a smaller spectrum. Here it's a huge spectrum. Chordomas, chondrosarcomas, angiofibromas, intra-dural lesions. I always call schwannomas as intra-dural. They're between the two dural layers. Intra-dural, petroclival meningiomas, epidermoids, histiocytosis, aneurysms, cavernomas. If you see this slide, this is, as you can see, these are the steps Dr. Arun nicely mentioned. The only thing which I would like to stress, that the GSPN must be dissected from always towards the geniculate ganglion. That means from anterior to posterior and never from posterior to anterior. Otherwise, you'll put traction over the seventh nerve. Second, your angle of drilling. If you always should expose the cavernous sinus, the posterior and the middle part of the cavernous sinus, so that you have an angle of drilling. Dr. Arun nicely showed that the cochlea is so near the arcuatemins. So if your angle of drilling is towards the gastric ganglion, you will always save two areas. One is the cochlea, second is the Glasgow triangle, that's the IC, that is important. And then the main aim of this approach is to combine the middle fossa and the posterior fossa into one cavity. This is our papers we reviewed, and then we studied, and we realized that the original Kawasi's triangle, the Hakuba's triangle, the Harshan Shekhar's triangle, they were triangles which was smaller, and making into a rhomboid. This was actually when I was training with Dr. Dolens, and we found that this became actually a rhomboid once you actually drill this and expose the cavernous sinus. It was nearly 2.5 times the size and by area. Petroclival meningiomas, the most common pathologies that we treat by this approach. So this is a redo surgery. That surgery has been done by a retrospective approach by another center. I'll just scroll faster. A standard temporal incision, temporal craniotomy, zygomatic osteotomy, drilling of the temporal base, and then that is the foramen spinosum. That is the middle meningeal artery being coagulated and divided. That is the always open the foramen ovale. That is the V3 being exposed, and then that is how you dissect the GSPN, sharp plus blunt dissection. Then the V3 is the simplest to dissect. Then you go anterior, and that is the this is the margins of your say, as you can see, it's a proper rhomboid, arcuate eminence, petrous ridge, gastric ganglion of GSPN, and that is the angle of drilling. So you're always towards the gastric ganglion. And then once you have drilled it and you want to communicate, we give a very basal temporal durotomy, a very linear one. Then you bring it down like a T right onto the V3, parallel to the V3, tentorium, and this is where you're cutting the tentorium, posterior to the fourth nerve. And when you're in a meningioma, when you're cutting the tentorium, you're already devascularizing a lot of part of the tumor. That is the superior petrosal sinus, which has been divided. You can coagulate, put ligoclips. Then the tumor is dissected and decompressed. The problem starts after the approach in petroclival meningioma. Approach is one part. This is, I always say that only half surgery is done till the tumor is exposed. Then the next half of surgery is there. You always need 2 or 3 hands. You always need 2 or 3 instruments. I love doing it between 2 microforceps. This is the fourth nerve. The fourth nerve is nice. It can be elongated. It can become elongated. It's already a very long nerve. The biggest problem is perforators of the basilar. Dissection over the 7th, 8th nerves. That is the posterior ones. That's the area of the meatus. Dissection over the 6th nerve. 6th nerve is always hidden where the tumor is coming from the clives. That is the 5th, which we can. That's the basilar trunk. All perforators must be preserved. Always use ionin. Then your dura can be primarily closed till the temporal base and the superior petrosal sinus, and then some fat and fascia, and that is the postoperative scan with no tumor. That these are some cases. The only problem with this approach in petroclival meningiomas, it is good for petroclival with tentorial with cavernous extension, But the moment it goes down the clivus or lateral to the clivus, you need a retrosig or a complete petrosal approach. I used to do some petrosal approaches, complete petrosal approaches earlier. Now I don't. I find complete petrosal approaches very morbid. So if the tumor is going lateral to the internal aortic canal, I actually combine a retrosig approach along with an anterior transpetrous approach. This is a paper which we found that if the tumor has this hypointense on T2 and has brainstem edema, it's a poor extent projection. So if a tumor is very much stuck to the basilar arteries, please leave some tumor. Do not, you can dissect over the nerves, but not over the perforators. You can damage the brainstem. And then we found through our molecular markers that HTK27ME3 loss and CDKN2A deletion was related to cavernous sinus extension and brainstem edema. What vitroclival chordomas, vitrosphenochlival chordomas? We usually any tumor which is lateral to the carotids, always microscopic anterolateral approach. If it is medial to the carotid, so this was operated in two stages. This case, first the lateral approach through the anterior petrosectomy, and then the midline one through the endonasal. I would have done the reverse now. I would have gone more extensive with the endonasal, and then still the lateral portion I would have done with the okay. Those times the extended approach was not available. But in this case, the chondrosarcomas have a lot of bone deformation as well. These are lateral, always an anterior features. Was an elderly lady, 60. You can see this is very calcified tumor with patient had hemiparesis and just scroll through. So again, a temporal craniotomy, zygomatic osteotomy, middle meningeal artery is being coagulated, divided, and then a very gentle separation, intra-dural separation over V2, V3 superior orbital fissure. We do not need the anterior ACP or the anterior clinoidectomy removal in these tumors unless there is an optic superior orbital fissure involvement. Then drilling of the anterior petrous rhomboid, gentle drilling. Again, the angle of drilling is very important. This is basal durotomy, T-shaped opening, so that your brain is always covered with the dura, and your horizontal cut is parallel to the spheropetrosal sinus, as you can see here. Then divide, this is the posterior fossa dura also open. So you can divide and then cut. You cannot put liga clips first, that I've seen. You cannot put the liga clips and then divide. You'll have to divide and then put liga clips, because that's the problem with the spheropetrosal sinus, because it is not two leaves, there are three leaves. One is the tentorium is also there. Then you cut the tentorium, and the tumor was very hard. We used all types of scissors, knife, sonopet, the bone cusa, and could finally remove. That is the sixth nerve. You can see how closely it is coming out from Dolores canal. That is the part, the remainder of the dura which was there, and that has to be sealed because the sphenoid sinus gets open. So, and then we use the K.V.L attachment. We have the skin over microscope. You can put this endoscope attachment and see whether you've left any tumor. And then we can primarily close the dura, and the last bit, put some fat there. Always put fat over the tegmen area, because that is an area where still micro air cells can be there. So patient did well. Schwannomas, always anterolateral approach. Anterior petrosectomy only for dumbbell-shaped tumor, so that this we already talked about. My previous speakers talked about amputation, auto amputation of the petrous apex. So here, this is one example in which you drill some more, as you can see. So we peel the two layers of the cavernous sinus, and the tumor is there because it's intra-dural between the meningeal and the membranous layer. We decompress, and then once we decompress, we start finding the bone behind it, and we drill that bone and decompress. Find out the fascicle in which the tumor is arising from. Fascicle is important. So that fascicle is important. The last fascicle, and that's a posterior fossa. And again, Here you don't need dural closure because you're already intra-dural approach. So fat and some fascia and then closure. We've done some histiocytosis, multi-compartmental epidermoid. I feel this is the only approach only single approach you can completely excise the multi-compartmental epidermoid. So again, small temporal craniotomy, zygomatic osteotomy. That is V2. Then V3. This is the exposure of the area of the GSPN. So the membranous and the as you can see, you're always dissecting and cutting, always parallel in between the endosteal layer and always towards the genicular ganglia. That's a drilling of petrus. Okay. Drilling flush with the V3 and the gastric ganglion here. That is the posterior fossa dura. That is the temporal dura. That is important. So again, it's a T-shaped incision. Then you open the standard subtemporal approach as you do always. Tentorial division. The only thing that this approach does is it helps you cut the tentorium through and through, right till the superior petrosal sinus to the posterior fossa dura. So you can actually look at the ambient cistern, the crural cistern, the CP angle cistern. That's the 7th-8th complex. And then you can take an endoscope and see the opposite side. So that is important because, and then subdural closure. Posterior fossa craniopharyngiomas, they're multi-compartmental. The posterior fossa component becomes challenging at times. And this is a case which was published, a video was published last year. This was the giant one, which posterior fossa component. As you can see, we do some VR planning. So again, a temporal craniotomy, a zygomatic osteotomy, widening of the foramen spinosum, coagulation and division of the middle meningeal artery. Then foramen ovale must be opened. Do not expose the V3 till you've opened the foramen ovale and foramen rotundum. Then peel the two layers over the V3 and the V2. I'm spending some more time in this because this is important. GSPN and the arcuate. So you see this rhomboid, and we are drilling this area now, and that is the angle of the drill. The angle of the drill, if you do not do an cavernous sinus exposure, the angle is towards the cochlea and towards the ICA. And then you open the dura that is parallel to the superior petrosal sinus. The brain is always covered with dura, and then tentorial section, that is the 4th nerve. So you're cutting the dura is open, and that is the tentorium, that's superior petrosal sinus. Divide and then cut and then put ligature clips. So the 4th nerve is taken care of, and these are the two layers of the separation from the 4th nerve, the 5th nerve, and then the ipsilateral 7th-8th complex, because the internal auditory canal would be at this junction. We go down and we see the ipsilateral, the vertebral artery, the contralateral vertebral artery, and we can just look at the lower cranial nerves. You can look at that, but you cannot really dissect over that. 6th nerve takes time. 6th nerve is something I'll spend a lot of time dissecting this tumor over the 6th nerve. It's very sensitive now. Then go to the opposite side. No coagulation, just instruments. Ipsilateral 3rd nerve. When we work, open the oculomotor trigone, work between the 3rd and the ICA. Also lateral to the 3rd. The basilar complex, the PCA. That is, you can now see the 5th, 4th. Here, the most important area, important structure is the anterior carotid artery. That goes into spasm. That is something this is an area we must be dissecting. You must have a papaverine irrigation all the time. So this tumor was completely removed. The patient improved. Basilar artery aneurysms, low lying. This is a choice where I'll just roll through this for the sake of time. You've seen this approach, and some of you must have seen. What the important thing after this approach is opening the oculomotor trigone. That means The third nerve can be opened from its dural sleeve, and the fourth nerve can also be mobilized by 3-4 millimeters. The third nerve is 7-8 millimeters. Then you can actually take the leaf of the dura up, and you can have a proximal control of the basilar and one PCA. And then you can coagulate, and then water bath coagulation of the neck, and preserve the perforators and put a nice clip there. Last video in which I'll be showing some P2 aneurysms. This is a complex P2 aneurysm in which we planned PCOM P2. The P1 was apoplastic. We harvested the STA, the superficial temporal artery. Did again anterior petrosectomy. So after doing the anterior petrosectomy, my ambient cistern is in direct line with the superficial temporal artery and the shortest line. There we can do an into side bypass over this. And then trap the aneurysm after doing ICG and Doppler. Then we did another case like that, but no, we opened the aneurysm and then decompress. So important tools. If I always keep the ICG ready, suppose I need to make sure that the basilar and the PCA is another, but I may not using unless it's an aneurysm. Doppler is a must. Forceps, small, big are must. So tips for dissection, master neuroanatomy, skull-base approaches, minimally invasiveness to the neurovascular structures. Bone flap is not so important. Skin incision is not so important here. Arachnoid dissection, high-speed drilling. Found that anterior petrosectomy extra-dural, which has a posterior cavernous sinus exposure along with petrous apex, gives a very big spectrum. Like I already showed, extra-dural lesions, chordomas, chondrosarcomas, angiofibromas. Intra-dural, like schwannomas. Intra-dural, petroclavimangiomas, epidermoids, basilar aneurysms, and pharyngiomas. Thank you.
Thank you, Dr. Ashish, for very nice, and you have shown different variety of tumors which can be accessed and removed completely, including the vascular lesions. Now, I think our this topic is open for discussion, and
ask our panelist.
yeah,
Misra,
may I ask,
Suresh and Dr. Atul is here. So I think they are the masters of this. I think they will throw some.
Can I share some slides?
yeah, please.
And after this, if we have some time, if Dr. Arun Srivastava wants to continue, can continue with his remaining presentation, so people will be benefited.
Thank you, sir.
Are you seeing my slides?
Yes,
Yes,
sir.
Yes.
Okay, very much.
I will highlight some points which is important for anterior petrosectomy. And this is the great man who initially described this approach, and an article which he gifted to me when I visited his. This is the whole thing, and this is what rhomboid or whatever you can call. And Arun described very nicely the importance of IAC in relation to arcuate eminence, and most important is he very, very well described that trigeminal impression. Say it is the Meckel's cave, this is Gasserian ganglion sits over the trigeminal impression. So if you have to remove the petrous apex, you have to mobilize V3 and Gasserian ganglion, and he told how to unroof foramen ovale to mobilize V3, and also he told the close relationship, and this is what we exposed. And there are some steps how to do that. I don't think I will go through all these steps which has been described by Suri. And also Suri stressed GSPN should be dissected from front to back, because in the front it is more in the sphenopetrosal groove, while posteriorly it will be more exposed. but many people do from posterior to anterior, and there is good article, and this is some way the petrous, the Cavas's bone should be drilled, and again it was stressed by Arun that importance is opening, first identifying the internal auditory canal, and this is a very important step which everybody should know. This is from Sebastian Frohlich's department, a checklist for petrosectomy surgery. And this, I think, will be recorded. People can see. I don't have time to go through all this. Everything is important. And my first question to all the two speakers and all the people there, will you do angiogram for a petroclival meningioma, which you are operating through anterior petrosectomy route? Can I get some people there? Arun, and I am sure Rajneesh is there. Arun is there, Rajneesh is there, and Suri is there. Will you do angiogram or not? Nobody is answering.
I can answer, sir. I can answer. Angiogram, I always get an angiogram for any petroclival meningioma, especially if it is going into the cavernous sinus and also the tentorium infiltration, for two reasons. Just to have a cross circulation confidence in my mind, so that if something happens to the carotids, if I am chasing into the cavernous sinus component. Otherwise, if it is a pure small petroclival meningioma, it is really not required. Initially, earlier, I used to do a venogram, also MR venogram, but now I've realized that if you're not damaging, if you're taking the small segment of suprapetrosal sinus very close to the fifth nerve and the Gaussian ganglion, then you don't need a venogram. But if you're dividing a big segment, then probably you must know the dominance of that sinus.
Okay, very nice. Suri, he stressed the importance of cross circulation, and which if the tumor is involving cavernous sinus. And let me ask Arun, will you do for all angiogram for all anterior petrosectomy?
No, sir. Actually, I just wanted to mention one more thing. Like, if the MRI picture is suggestive of increased vascularity in the lesion, and as sir has rightly said, if I really want to know the relation of petrous ICA and the ICA which is lying beneath the petrolingual ligament. If I'm not sure about the relation of that particular portion of the ICA with my lesion, then only I'll go for that. Otherwise, not for all the lesions.
Okay, and Rajneesh and Narasinga Rao, what about your call on this?
For a simple petroclival meningioma, which is not going to cavernous sinus, we have not done angiogram for that.
Okay, so and Narasinga Rao.
Sir, just only one thing, that more than an angiogram, a CT angiogram with the 3D reconstruction gives the anatomy of the ICA along with the tumor. Nowadays, you can sit on the console and really reconstruct the tumor and as well as your ICA. I think that would be the best thing to do in my view. Nevertheless, if the vascularity is high, I go with Arun that you can get an angio also.
So this is okay, fair enough. I got answers from all big people. Initially, this is the one, this to see the tumor blood and see the displacement. But more important is to see the venous anatomy. So to tell, say you have the endosteal dura and you have the dura propria. And the from sphenopetrosal sinus, the venous drainage to cavernous sinus and then to the pterygoid plexus goes underneath the endosteum. It is not bit above the endosteum. But sometimes when this anatomy, when there is a sphenopetrosal or sphenobasal drainage, then say if you do your intra-dural dissection, there will be profuse bleeding. We saw one of the videos, I think Arun's video, there was bleeding from foramen ovale. Probably there may be this type of abnormal venous drainage. So it's not only to look at the cross circulation of the arterial and also the venous anatomy, especially vein of Labe and torcula, but more also to see the abnormal venous drainage. If it is there, it is a interdural approach is a relative contraindication. And so this is what I was telling you. You have the periosteal dura and you have the meningeal dura. And if you have the abnormal veins, venous drainage coming there, then you cannot go through this approach. You have to go totally extradurally. And some of this has been addressed by Manas in his an article. This is something again which I love. Arun was telling complete anterior petrosectomy and extended middle fossa approach. Importance is unroofing foramen ovale, mobilizing V3 and working. Say we have the carotid artery. So underneath V3 and Meckel's cave, it is the petrolingual ligament, which is there, which is separating it from a carotid artery. So you get the lateral carotid there, and you get the petrous carotid underneath GSPN. So this has been very nicely described. I don't have to do, and this is something mini combined transpetrous approach. Suri correctly told he has moved away from all posterior petrosectomy, but this is what some people do. This is what is called the Trotman's triangle. So just they're mobilized it for, they take out the sigmoids, work behind the labyrinthine structure, identify those some bone drilling for retraction of sigmoid sinus and work in this area between the temporal lobe and cerebellum, which people call mini petrocell, mini combined transpetrocell approach. And the advantage is, what Suri has correctly told, the old surgery Arnold used to cut all the nerves. This mini petrocell, which these people describe, you can spare greater occipital nerve, lesser occipital nerve, because your incision is such a small thing. And this is also which has come from Roy Daniel. This is a combined petrocell intertendorial approach. This is also the two leaves of tendorium, and nicely discussed by Arun. Endoscopy is coming. So I will ask some thing. This is a petroclival meningioma, correct? Mid petroclival meningioma. It's a petrous bone. Clival bone, upper clival area is behind the dorsum. And as anatomy has correctly shown, the upper petroclival means it is just underneath the cell, lower part of cella turcica will be there. So what approach will you do? All three, all of you can tell what approach will you do for this case? Suri.
Sir, cannot see your slide.
Acha, you cannot see at all, eh?
I don't know. I can see your face, beautiful face, no slide.
So slides are not seen, eh?
No, we are seeing, sir.
Slides are seen.
We are seeing the slides.
Suri,
He
I
doesn't
don't know.
want to see.
I don't know. You are not seeing.
No,
Okay,
sir.
others can.
I think you need to go to the Dr. I mean, Suresh Nair sir's screen will be there, sir. In that you have to click, I think.
No, so you people are.
We are
Yeah, I am
seeing.
able to see.
No, you are not seeing my slides, eh?
We are seeing. We are seeing.
Everyone else is seeing, sir.
Okay, so this one, it's a correct classical petroclival meningioma, which is in the upper area, upper petroclival, correct case for which we did through anterior petrosectomy. I will not show the video. And this is the, after surgery, the bone removal apex has been removed. And this one, this is involving the mid-clival pit actually. It's a big meningioma, classical petroclival meningioma, but this is involving the mid-clival pit. So what approach will you do, Suri? Suri, we are not seeing my picture, but there is a petroclival meningioma in zone 2, or what we call between the level of lower border of cella to internal auditory canal area. That area you have a petroclival meningioma involving the clival pit. So what approach will you do?
If it is not going lateral to the internal auditory canal, then I'll go for the anterior petrous. Otherwise, Dr. Goel's approach, retrosigmoid supracerebellar.
That you told also. You will do
We usually combine.
Okay, so this patient we took out through the old classical posterior petrosectomy approach, and we could achieve a good decompression. But as you said correctly, we have moved away from these morbid approaches. This is a large tumor, large sphenopetroclival meningioma involving upper, middle, clivus with cavernous sinus extension. So what approach will you do, Arun?
Staged, sir, staged surgery.
Yeah.
I'll go for this left-sided approach. I'll be doing the extended Kawase, means I'll be doing the Dolenz Kawase for this approach. And middle fossa and the part of the tumor superior and medial to the meatus probably will be removed based on the character of the tumor, how it's behaving. And the rest of the tumor, which is actually below and lateral to the IM, can be removed with the second stage surgery in the form of ristromestoid. That is what I.
Okay, fair enough. What about Suri? What will you do?
Sir, I can't see the picture.
Okay, sorry, it's a very large meningioma, very large meningioma.
A large petroclival.
Cavernous.
Okay.
Narasinga Rao?
Sir, I would also go for probably staged, but petrosal approach in which you combine with the anterior petrosectomy and the posterior petrosectomy, where you get a lot space from the fifth nerve to lower cranial nerves exposure can be done. With complete drilling, of course, it will take a long surgery. You have to do the bone work on one day and then go for the tumor. You combine the subtemporal incision with the pre-sigmoid incision and cut the tentorium.
Okay.
And classically you open
do a combined.
I can see it now, sir. I think
Going in the
middle
cavernous
fossa
sinus.
component is very big also. Combined
And how about Rajneesh?
No, I'll stage this tumor. I'll first go by a middle fossa approach, and in the second stage the retrosect.
I don't know whether Atul Goyal and Misra, they are all there. I don't know. Because
Dr. Goyal sir's comment is needed.
Atul is here.
Yes,
Yeah,
Dr.
yeah.
Sir. Yeah.
Atul is
No,
here.
this is
both are
Sir,
here.
he is there in the panel.
Atul,
this
what
one
will
is
you do?
Both are here, very quiet.
Both are there. What they will do? Atul.
No, this one, can you hear me?
Very well.
Yes.
Yeah, this one is indeed quite a large tumor. And in both the compartments, both in middle and posterior fossa, both components are quite large. And you know what? It can be done. Staged operation may not be a bad idea. I never do staged operation, I must tell you. I have never done. But for this particular case, maybe I will try to get in one stage both the compartments. I think I will try to do in one stage both the compartments. And you know what's basal subtemporal for the middle fossa and retrosigmoid for the posterior fossa, and leaving the middle part of the petrous bone intact. So come from here and come from there can be done in one stage. But it is, you know, I will not contest if it is done in two stages.
What about Misra? What will you do?
I'll tell you the first case, supracerebellar approach. Semi-sitting, the first case you showed, right? The second case, retrosig. The third case, staged, middle fossa followed by retrosig.
Okay, I got it. Okay, so what we did is we did a combined petrosal anterior and posterior, and we did in one stage both and took the tumor out. And this is another case. This is just, you can see a dead, more of clivus, petroclival meningioma. How will you operate, Mr. this case?
Same. So semi-sitting position, supracerebellar approach.
Supracerebellar. Atul?
Retrosig paracerebellar, we call it, which I actually wrote 1991.
Okay.
Now
so
this approach, I will like to say that this supracerebellar approach is quite an approach for this case, and this can be possible and quite elegantly possible.
Okay, and how about Rajneesh?
Professor Suresh, I think we would like other and their views on the.
Okay. So this, as correctly what Misra and Atul told, we removed through a paracerebellar approach. And retrosigmoid approach, since we are tuned to acoustic surgery, many of these tumors can be removed And this is what I was talking of K.V.L pit. Say if you go through a pre-sigmoid, this is a sigmoid sinus, this tumor you cannot see actually. And now these days you can see with endoscope, but with microscope it was difficult to see the K.V.L pit. And if you do a retrosig approach, you can take out that also. And say suppose this is for Arun, there is a large tumor, middle fossa with suprasellar extension. What you will do? Very large tumor.
Single approach, sir. It will be done with the the dual Kawase, and even the cavernous sinus portion can be removed. And with adding Kawase to that, it will be addressing whole tumor from anterior to the posterior, even to the whole tumor of the posterior fossa compartment.
Okay,
Sir,
Misra,
sorry to interrupt, sir. This there are some online questions.
okay,
almost
okay.
getting over.
Then I will conclude. Okay.
Sir.
So best approach is the one that is most familiar and provides greatest exposure to the surgeon. And as what Atul told, we also moved away from this fancy petrosal approach to retrosigmoid approach. But still, anterior petrosal approach is one of the greatest approach. Thank you very much. I will just come out. Okay.
Thank you so much, sir.
I want to show one case, and can I share my screen, please? Let me share my screen.
And after that, the panelists can see the questions which are there in the question answer. This thing.
Panelists have to
I want the panelists to just see the questions.
Questions, a question answer. Two are.
Let us take their vision of Dr. Misra and Dr. Atul, what they have to conclude, means say about the anterior petrosectomy, few words.
Supracellular approach, petroclival videos. How can we enlarge our dural opening after temporal durotomy?
I can't see any questions. I don't know. Where are the questions?
Questions are there.
Where?
One question is the supracerebellar approach to petroclival lesions. Any videos or articles regarding it? Of course, we can share some videos. Then second question is, how can we enlarge our dural opening after completing temporal durotomy and tentorial cutting? Okay, Misra, you can take that question. This is from Pavan. Pavan, how can we enlarge our dural opening after completing temporal durotomy? Temporal durotomy. Which approach he is talking, we don't know. And
No, I think he's talking a middle fossa approach. So you have to cut the superior petrosal sinus. You have to put clips or ligate and then cut it. And then that will be you've already done a temporal durotomy, you're saying. So basal temporal durotomy, and then after that you have to cut the petrosal sinus, superior petrosal sinus.
And the first question is from...
No, just a minute, Suresh.
Yeah.
Now, you know what? Anterior petrous anatomy that we have seen from Arun and others is absolutely important for those who are going to do skull-base surgery. And those who do not know the anatomy cannot do skull-base surgery, that is for sure. And we have been dealing, and I have been particularly studying the anatomy on cadavers and drilling and all those things for several years. So how this anterior petrosectomy can be expanded, that is another question. You see, in the anterior petrous bone, there are three parallel structures. One is the eustachian tube, one is the carotid artery, and one is the greater superficial petrosal nerve. Greater superficial petrosal nerve emerges from the geniculate ganglion, as we have heard several times. So what I had done several years ago to expand the anterior petrosectomy, to expand the Kawase's exposure, I had cut the greater superficial petrosal nerve. As Suri also said, it has to be cut away from the geniculate ganglion, not towards the geniculate ganglion. Then drill off the geniculate ganglion and the tympanic and labyrinthine segment of the facial nerve and mobilize these two segments behind. So that maneuver has been, which I described in 1995, has been published on several occasions, even by very reputed skull-base surgeons, and one very famous paper by Ohata. He also mentioned about how to mobilize the geniculate ganglion along with the tympanic and labyrinthine segment over the eustachian tube, over the carotid artery, over the petrous bone. So that is one possibility to expand the petrosectomy. Second thing, as we have heard on several occasions, and I have been personally doing all these kind of middle fossa approaches for long period of time. This approach of supracerebellar that I described first time in the literature, and it has to be recognized, this supracerebellar term in surgical neurology at that time was a big journal. Supracerebellar approach is a beautiful approach, but for that approach, the bottom line is you have to use sitting surgical position. In lateral position, you can do it, but in sitting position, it becomes a much better option because sometimes, it is a little bit cumbersome to retract the cerebellum and things like that. So supracerebellar approach cannot be forgotten. And as in my own tenure, I have moved on to this supracerebellar approach quite often for pictoclavian meningioma. As regards, I little bit also like to tell you about the intra-dural approach, which Suri keeps on mentioning, Kawase approach and Dolan's approach. I'm wondering why he's always hesitant to say this intra-dural approach was described by me. I'm a little bit not too happy with this kind of, ignoring of a published work. An intra-dural approach was first described by me in 1994 for trigeminal neurinoma. And then we expand. This is the most highly cited paper on trigeminal neurinoma. There is no other paper more highly cited than this. And this paper has been ignored in all the presentations. And to tell you the truth, I sometimes get disturbed by this kind of ignoring of Indian published work. Intradural approach, how the petrous apex is eroded by the trigeminal neurinoma, how, as Dr. Arun had mentioned, or self-petrosectomy, petrous apexectomy, and these kind of things are all described. Means it is a little bit troublesome for me on occasion, but understanding petrous apex anatomy, understanding the dura, understanding the petrous apex carotid artery, understanding the facial nerve in that area, understanding when you're going for more expanded views for chordomas, for instance, I have described middle fossa subjacent ganglion approach for clavicle chordoma, which is such a fantastic approach that I described. And how the carotid artery is displaced by these tumors, one could have mentioned, but completely avoided. So these kind of things, pictoclavicle surgery forms the baseline of a skull-base surgeon. Those who have to do skull-base surgery, any kind of advanced skull-base surgery, have to learn this anatomy not on direct surgery, but on cadavers, not for 1 day or 2 days, for a prolonged period. You have to live in the petrous apex, cavernous sinus, and one message that can be given, and that message should be given, is that anatomy is the key. Understanding anatomy on cadaver dissections is absolutely mandatory. And the most important is the understanding of the tumor. You have to understand how you can break the tumor, how you can demolish the tumor, how you don't need much exposure in certain tumor, how you can avoid extra exposure. You see, this understanding, I think, has been the bottom line of my own growth in this subject. When initially I used to have much bigger exposure, now my exposures are limited. You will say why they are limited, because now I can feel the tumor. When I see the scan, I can feel the consistency of the tumor. I can feel the vascularity of the tumor. I can feel how it can be entangled within the cranial nerves and the carotid and the basilar artery and perforated. So this understanding. So more you are doing, more and more you are doing, more you learn about skull-base.
Thanks, Atul. Your points well taken. Rajneesh, can you show that case?
Yeah,
Thank
yeah,
you.
I just wanted
Yeah,
to
please.
show the case.
And there was one question, say if you have a large middle fossa, posterior fossa tumor, which we will do first if you are staging. First decompress through a retrosig, decompress a brainstem, then come from above. That's what we used to do. Okay, that was the first question. Two-stage
Yes,
surgery.
I think I am also a panelist. I don't know. Am I a panelist?
Yes, yes.
Yeah, I'm sorry, but I'm unnecessarily wasting my time here, I think.
No, I asked, I told about you to speak, but Please, I asked Dr. Misra to put his views.
Okay, this is, I think, Rajneesh. You can finish, Rajneesh. Then I'll talk.
I just wanted to show this
Yeah,
case.
yeah, please, go ahead, please.
This is the case which we had operated long back. I think Dr. Professor Suresh Nair will remember this patient. So, what approach to all the speakers can you? What are the how we can approach this tumor? Very largely calcified tumor. Extending from middle fossa to posterior fossa and quite superiorly also.
Was it enhancing anywhere or just completely calcified?
Mostly calcified. I mean,
it looks completely calcified. Do we even need to operate?
What are the symptoms?
Yeah, अगर वो पत्थर बना हुआ इतना साल से तो बड़े रहने देते हैं।
Sometimes may not be that hard. It can
That
be.
is a very fantastic thing that you said, Ashish. That, most important is whether you need to operate this pathar, this stone which must have been lying there for ages, whether it needs to be operated or not.
I think contrast MRI and then prove if there is some contrast enhancement around
Very
it.
long back. I think it is done in 1997 or 1996. MR is.
If this case comes tomorrow, then what will you do? Just, I think, what
Dr.
are
Misra, sir.
the senior panelists here, Dr. Misra, Dr. K.V.L.
Dr. Misra, sir.
No, I can't. I mean, I need to know the patient's condition. What are the symptoms? What is the MRI plane? I mean, this is CT, plain CT. I mean, there's nothing I can advise on this. There's obviously very, we don't operate on a scan. We operate on a patient. So we need to know what is the patient's presentation. We need to know why did the patient come to you? What was the patient's presentation? What is the MRI? What is the T2? What is the contrast? What is T1? Before I can advise. If it is some enhancement is there and the patient is symptomatic, it's a very, very major surgery. It's not easy surgery. If it is calcified and it is enhancing and the patient is symptomatic with raised ICP or brainstem compression, it's a very, very major surgery. It's a very high risk major surgery, which we have done some of these cases, but I will have sleepless nights before I go for this. But if it is amorphous calcium, then you can take it out. Sometimes it is amorphous calcium. So this is, you need to have the bone window. This is no bone window. This is a plain CT scan.
Yeah, these are the only pictures available. And
anyway, go ahead. What do you tell us? What did you do?
We had operated this tumor by posterior petrosal approach to remove this part of the tumor. And in the second stage, we went with the transfilion frontotemporal. And we could remove majority of the tumor. And this was
that means Dr. Misra is right. So it must have been a amorphous one.
Okay, Misra, go ahead.
Yeah, I just quickly a few comments because before I go back. The first series of petroclival meningioma in a presentation in India was in 1990 by us in Manipal meeting. Was it 1990 or I don't know?
91.
91. Was it 91? So that was 11 cases from Sri Chitra. I don't think anybody had a series before that. This was the first time. But why I'm saying that, after my presentation, which I was very proud of, Dr. Sambashivan got up and asked me, it was very nice, very good. But are we taking out the tumor from the patient or the patient out of the tumor? I was very upset. But over the period of years, something which I've learned is very, very critical. Leaving a little bit of tumor there doesn't make a damn difference for a meningioma. Whatever you do, the patient tumor is going to come back in 20 years' time, even if you do a total grade 1 Simpson excision. So if I am much more conservative today than what I was in 1990s and maybe up to 2000. But then things, you see the patient afterwards, the patient's condition afterwards. Of course, that doesn't take away the presentation, which are beautifully done by all the three speakers. Very nice presentations by Arun, Dr. Gupta, Ashis, and a lot of things to learn. And we also, there was a meeting which was organized by Dr. Dharkar in Jaipur. on a CP angle symposium. I think the meeting was CP angle symposium, and he brought out a monograph, which we presented in. We wrote in that in the we didn't call it actually supracerebral. We call it retrostic paracerebellar approach. As we call it supra and paracerebellar approach, both. And this is a series of tumors which are operated by that. So most tumors today in my practice, if it is mostly posterior fossa, they go through either a retrosig or if it is central clival through a supracerebellar approach. If the middle fossa, then it goes for a petrosal approach, anterior petrosal approach. I have almost, for many years, I haven't done a posterior petrosal approach for meningioma. I have done some of the aneurysms, basically trunk aneurysm, I have done it, but not, I mean, at least for last 10, 15 years, I haven't done a posterior petrosal approach. I have done some anterior petrosal approach quite often, and more often in chordomas and the trigeminal sonoma. Anyway, you don't need to do anything because the petrous apex is already gone by the tumor. But chordoma, we very nicely shown Arun showed that the transcavernous approach. I think this is a beautiful approach, particularly for chordoma. You don't produce any morbidity because the tumor gives you all the space there. So these are some of the things, but one has evolved over a period of time. One has become more conservative over a period of time, and we have become much more sensitive about the patient's outcome rather than the scan.
Dr. Misra, what position you give for the supracerebellar?
Semi-sitting.
Atul also said the semi-sitting, no?
So that's the only thing I do in semi-sitting. I used to do a lot of letrosig in semi-sitting. I don't do it anymore unless I have to do a central clival tumor or a high clival tumor or a clival meningioma or a high clival chordoma or the pineal region tumors. All these three things I use only semi-sitting. I don't do it anymore for all other tumors, which I used to do, but we had problems. Ansu actually is in the panel. Ansu has put in a question. Ansu has a vegetation. During his vegetation was the prospective analysis of semi-sitting position, and that was I think for 4 years. And we found out that there are problems which is beyond the surgeon's kind of control. So I have moved away from that unless it's absolutely essential.
Any other questions from any speakers?
So if nothing, Dr. Roopesh?
Yes, sir.
Vote of thanks, Roopesh.
Yes, I think
before Roopesh finishes off, finished by the address by Thanksgiving. Now, I just want to know that to all the panelists, sir, there are certain situations when you open the dura, the brain is very tense. I mean, you want to do before doing any procedure, the procedure itself, after just doing a craniotomy itself, the brain will be very tense. So, what precautions we need to do and how to go about it at that point of the time?
Narasinga Rao,
I never operated a tense brain. You have to have something to make it lax, otherwise don't do it. You can have all the diuretics, mannitol, whatever. If you have a high central clival tumor, not a very big tumor, then you can do a lumbar drain. But otherwise, you need to have proper anesthesia techniques. And if you has, for example, somebody who was a semi-sitting position, this problem is very, very, is very unusual for a semi. That's a great advantage of semi-sitting position for supracerebellar approach. The brain is always lax. But if you're doing in recumbent position and especially for subtemporal approach, quite often we have, if a subtemporal approach, we use a lumbar drain. The other thing you can do is open up the sylvian fissure rather than going first to the subtemporal approach, release the CSF from there, and then come up for the temporal lobe retraction, whether extra-dural, intra-dural, whatever.
See, on the other hand, let me just a little bit elaborate on this. You see, these are majority of these skull-base tumors are benign tumors. They are long-standing tumors. They are meningioma. They are chordoma. They are epidermoid. They are trigeminal schwannoma. The brain is not going to be too tight. That is one bottom line. They are not malignancies where the brain has to be tight. Second thing is, all our surgery, all our life of neurosurgery, we have to learn how to make a tight brain relaxed. As Basant has said, lateral position, lumbar drainage, intraoperative lumbar drainage is a fantastic tool for anterior petrosal operations and basal subtemporal operation. Is that lumbar drainage is a very fantastic thing. And of course, posterior foci is much better because you can open the cisterna magna early in the operation. But sometimes the tumor is too huge, too large, like some trigeminal neurinomas can be massive in size. So in those cases, you can actually little bit remove the inferior temporal gyrus if you have to remove, and then attack the tumor and start debulking aggressively early in the operation. And once you debulk the tumor more aggressively, the brain will ultimately and eventually relax. So I think there is an option of removing the inferior temporal gyrus in some situations, which may not be too rare situations. So that is another thing that can be considered.
I just want to make one comment. Sometimes this, like Atul said very correctly, the trigeminal sonoma could use tumors, and there's a problem. The brain is bulging. You don't want to go for an intra-dural approach. We have actually done, the tumor is actually bulging there. So sometimes it may be easier to open up the dura rather than doing inter-dural. Decompress the tumor, open the dura, decompress the tumor under the temporal lobe before you go for the classic approach. And that has happened. That has happened because that inadvertently, I mean, the moment you start, the dura has tearing off, and then it's much easier. You decompress very fast and then come back and do the final excision. But the many subtemporal approach, we use a lumbar drain. Whereas in posterior fossa approach, we don't mostly use lumbar drain.
Roopesh.
Okay, so what a fantastic webinar today. We had the legends of skull-base surgeons of our country, and with the excellent experience shared by them over what they have learned over the period of years, and again stressing upon what is safe neurosurgery and safe skull-base surgery. I think thank you very much to all the expert panelists and the speakers who made this webinar, made this approach looks quite easy, but then as was stressed upon, basis cadaver anatomy. So Arun Srivastava showed beautiful cadaveric pictures and correlated with that. So thank you, Dr. Arun. And stressing upon again, so this is a webinar on back to basics, and stressing on the basic neurosurgical procedures. We started with the diurnal craniotomy, anterior craniotomy, then anterior petrosectomy. I think now we'll concentrate more on the posterior fossa in the coming webinars. But skull-base is all about exposures, and that's what we are learning every day. And once again, I thank all the expert, legendary speakers and the panelists for making this program very, very successful. And thank you very much. And Hemant sir, you want to have any final comment on this?
You asked me or whom?
Yes, sir.
So our aim was back to basics, and particularly on the anatomy, so that the younger generation and those who are in practice, they learn the basics of these approaches, and that is our aim. So in the next few webinars, we'll be going on the posterior fossa and far lateral or other common approaches which are routinely used. And we are really thankful for such glorious and so eminent our speakers and panelists and every participant here who have enlightened us and all the younger generation and other neurosurgeons. I think this was very educative webinar from basic to high modern neurosurgery. Thank you very much, everyone. Let us see you next month.
Thank you, sir.
See you in the Skullbase Surgery Society meeting at Chennai, October 30th, 31st, and 1st of November. Thank you.
Thank
We
you.
have
Thank you.
Thank you, sir.
we have 2 more webinars before that, sir.
Thank you. Namaste, everybody. Atul sir.
Bye. Bye.
Thank you, sir. Thank you.
Good night.